Hi there, welcome back to the program Your Doctor in COVID. I'm Dr. Mahendra Carpen, Head of Medical Services and Cardiology at the Georgetown Public Hospital Corporation. And today we continue our conversations with Dr. Shazima Shah, Infectious Disease Specialist at the Georgetown Public Hospital Corporation. She has been integral and an essential part of the management of all COVID-19 patients presenting to the Georgetown Public Hospital Corporation. Remember, if you have any questions, you may send a WhatsApp message to 620-6275 or send us an email at docandcovid@gmail.com. Dr. Shah, welcome once again to the program.
Thank you.
So we're continuing our conversations, and now we're going to ask you a little bit about your clinical expertise and management of these patients. And how are patients with COVID-19 managed, first at the Georgetown Public Hospital, and now that we've moved them over to the Lillian Dahl Ocean View facility, how are these patients actually managed? Let's talk about the ICU patients and then the transition patients.
No problem. So these patients that come to us with COVID, they just don't have COVID. They have other problems. So they might have comorbidities like diabetes, hypertension, heart issues. So anything else that they come along with, as well as their COVID, we treat them as a patient, not just that one aspect of it. Patients with COVID, they're treated symptomatically, and there are additional treatments that we add. So we add our convalescent plasma, we add our remdesivir, depending on the severity of illness that the patient would come with. And we do a lot of respiratory support. So these patients have a lot of difficulty breathing, so they're placed on CPAP machines or they're intubated, depending on their level of severity.
So do you actually see patients who are purely COVID admitted to our ICU or transition area without any comorbid conditions that you would have mentioned?
Rarely do we see patients with no comorbid conditions come into us. We've had very young patients, but they've all had some form of comorbidity before. So diabetic patients, for example. Some didn't know they had these comorbidities until we were monitoring those aspects, for example, their sugar levels, and then realized that, hey, they're diabetic here.
Okay. So would you care to guess like a percentage of persons who would have been in the COVID ICU who had no comorbidity, but all they had was a COVID infection that affected maybe their lungs or something else?
That's a very low percentage. I would say less than 5%.
Less than 5%. So the majority, 90+% of persons admitted to the COVID ICU had some kind of comorbid condition.
Correct.
Well, thanks very much for sharing that piece of information. Now, earlier you also mentioned CPAP. For our viewers and listeners, would you care to just explain that a little bit? What is really CPAP and how do we use it? How do you think the patient feels and how they respond?
So CPAP is continuous positive airway pressures. So it's a machine, so it's kind of a mask that they put on. It's strapped with a harness onto your face because you can't hold it. You have to have that seal that comes with the mask. So it's placed on the face, strapped on with a harness, and it's hooked up to a little machine that has an oxygen supply. Now, that could be given to the patients intermittently, meaning for 2 hours to try to increase their oxygen saturations. We try not to do it on continuous CPAP, but intermittent is what we aim to do. The reason for this is because it's so uncomfortable to have that on. It's like a gush of air that's going in there whether you want to breathe or not. So it's very uncomfortable. Patients complain, so that's why we do 2 hours, give them a little rest, maybe drink a sip of water, something to that extent, and then continue.
I could imagine that it has a dehydration effect on patients.
It does.
Yeah, so that's why the water, etc. Okay. And in terms of the management of these patients, you mentioned convalescent plasma and remdesivir. Those are fairly new, novel therapies for anything in Guyana and the Caribbean. Can you tell us a little bit about how we started? You could say, let's start with convalescent plasma. What was that process like? I know you were integrally involved in the initiation and management of that in this country.
Yeah, so the convalescent plasma was actually started before the remdesivir. When we started, so convalescent plasma, you need to have someone that was tested positive for COVID and have recovered. Then they donate that plasma, and that's how we get convalescent plasma. So it's not readily available to the extent where we have a whole bank filled with it, because not anyone can come and donate that. It's a specific plasma, so we were limited on the amount that we had. But as we got more positive patients, we got more persons to donate, and hence more plasma. What we did is the patients that were ill, taking very long to recover, the convalescent plasma would sort of add some antibodies to sort of fight COVID off. So it was pretty useful. It still continues to be useful. We first informed the patients that this is something that we are administering. We get consent from the patients before we actually go ahead and give them convalescent plasma. So it has been proven to work. It has been working with us to some extent. It doesn't cure COVID, but it helps the immune system to sort of recover.
Great. And what about remdesivir? We have seen in the press, and there's been some controversy about guidelines being changed, etc. There's talk about it being expensive. What has been our experience or your experience in initiating remdesivir for our patients at the Georgetown Hospital?
So remdesivir is not a drug that anyone can use. It's not one that we can give the patients that are isolated home to use. It's only given to those that are moderately ill. So if you're severely ill and you're already on a ventilator, we do not give you remdesivir. But if you're moderately ill, you're having shortness of breath, you're having a difficulty breathing there and all the symptoms, we can give you remdesivir. But before we do so, we need to ensure that your kidneys, your lung and everything, your kidneys and your liver and all those other parameters are within range to actually use the medication. Remdesivir, and this is what the articles have been showing as well, they do not cure COVID, and remdesivir, all it does is decrease your hospital stay. So probably without the medication, you'd stay longer in hospital and get a little more complicated. But with administering remdesivir, we can discharge you a little earlier. You get better faster.
Yeah, so we know that longer hospital stays are associated with more complications, and that's
Correct.
Separate and apart from the cost of keeping a patient in hospital. So shortening their hospital stay, you say, has a net benefit, wouldn't you?
It does.
Absolutely. So as a frontline healthcare worker dealing with COVID-19, it's new, it's scary, we are learning things about it every day. What challenges do you have or your team members have in dealing with COVID-19 as a frontline doctor?
The challenges of dealing with these patients is that you're putting yourself at a risk every day to just go to work and to deal with positive patients, because it's not a case where it's one day you see a positive patient and then you don't for the other couple days. No, you're going in to deal with these positive patients every 12 hours, for example, with 24 hours break. So it's a risk that you're taking. It's putting yourself out. I mean, you're using all the protective equipment that you might need, but the risk is still there. So one is the risk. Two, the hours are pretty long. Our COVID team has been working very long hours. When they go in at 8 in the morning, they leave at 8 at night. 8 at night is when we hand over. So sometimes you leave at 9, 10. If the work isn't done, the other team's there, you need to assist. So the working time's long, the risk that is involved with it, and just dealing with everything else that comes along with COVID.
It's impressive and remarkable that the team actually has that kind of attitude and dedication to dealing with these patients, despite all the challenges and personal risks that are involved. How long does the team members actually stay in the COVID ICU with patients? I know there's a rotation system. Tell us a little bit about that. Because
we're in full PPE, as in either a hazmat suit or a level 4 or 3 gown, and we wouldn't be taking our masks off at all. During that period, we stay for 4 hours with the patient. And the reason for that is in the ICU, it's different from any other ward. In the ICU, you would have aerosolization because of the patients being on a ventilator, etc. So we stay 4 hours in, you take a little break, and you go back for another 4 hours.
Okay. And how do you cope with the stress of like the mental stress involved in knowing that every day you're coming into this environment, you may be at risk personally, you have to go home to families, etc. And you may be seeing patients who you've come to develop relationships with not do well and take a turn for the worse. How do you actually cope with that stress?
It is stressful, and particularly so when you deal with a patient that you got a chance to know. All our patients, they spend a little while there, so you get to know them. You talk to them every day. You try to make them feel comfortable. In our unit, we have no visitors, so they have no family coming to see them, etc. And that's just because of an infection protocol. But we try to make them as comfortable as possible. But with that, at the same time, we are dealing with making them comfortable, and I just lost it.
It's okay. So I can understand that this is a very stressful and emotionally draining part of the job. None of us who interact with people on a continuous basis, especially on a long-term basis, can remain completely removed from people and their circumstances and their situation. And are there any specific remedies or therapies, interventions that are available to our healthcare workers to help cope with the stress, the mental anguish of going through these situations?
Our mental health department, our psychiatry department, the social workers there have been very helpful. They've reached out, so any particular staff that needs to speak to them at any point or just wants to share some concerns or just anything of that nature can reach out to them and get support there. So we do have mental health support at the hospital. So
they're part of the team, not just for the patients, but for their colleagues,
the physicians,
their healthcare workers as well. And you and I as doctors, we see our things from our perspective generally, but can you say a little bit about the nurses and the other healthcare professionals involved in the management of these COVID patients in the ICU and transition area?
So the nurses work super hard with the patients as well, because we've had the same group of nurses since the start of COVID as well. So they've been working their shift systems. They face the same challenges as we do, personal challenges, etc., the long hours. So the nurses have been very instrumental with working along with us, and we've grown to share a relationship with the nurses there. So it's a pretty closely knitted family with the ICU.
Yeah, nurses and doctors together.
Correct.
And I assume, and I'm sure there are other persons as well, the attendants, the ward clerks, the people who clean and take care of, you know, the environment in the area as well.
We also have our physiotherapists on board with us too. So.
Yeah, and everyone has to wear their PPEs?
Correct. Even the cleaner has to go in fully protected with his N95 and his full hazmat suit or his level 3 gown, depending on availability.
And there was training involved in making sure that everybody knows how to...
Yes. So our quality assurance at the hospital, they would have trained these individuals, the cleaner, etc., how to don and doff PPEs. So he was fully trained.
So tell us a little bit about donning and doffing of PPEs. What does that really mean, and what are the critical components or times or parts of that process that one has to be aware of?
Yeah, so donning your PPE is putting on your protective wear. So PPE is your personal protective equipment. So there are different steps in putting that on, because it starts with you putting on, we double glove. So it's one glove, it's the head tie, it's your face mask, your goggles, your gown or the hazmat suit, depending on which one you have, your shoe covers, and then we glove again. So that's your second pair of glove. Putting it on is sort of the easy part. Taking it off is the riskiest part. And the reason for this is that you don't want to have any glitches when you're taking it off, because then is when you can actually expose yourself. So you take everything off and leave the face mask as the last component of you taking off your PPE. So that's the last thing you take off, and then we have a full shower head to toe, and then you leave the decontam department.
Do you know of any colleagues or persons in the area who would have developed symptoms or tested positive for COVID-19 while working in the area?
I know for sure, so far at Georgetown Hospital, we've had over 60 staff members that has developed COVID. In our ICU unit, we've had close to 15. that tested positive at some point.
And this is despite taking all recognizable safety measures.
Correct.
And was there a shortage of PPEs that would have contributed to this?
At no point there was a shortage of PPE going into the unit. So there might be an issue where we don't have available outside, but that's quickly fixed. It's available and then you go in. So there's always PPE once you get into the unit. So it wasn't a case where there wasn't PPE at all.
Okay. Well, thank you very much, Dr. Shaw. We continue our conversations with Dr. Shaw after we come back. But remember, if you have any questions or comments, please feel free to send a WhatsApp message to 620-6275 or send an email to docandcovid@gmail.com. Thank you very much for watching or listening.